Sorry, it took me a couple of minutes. I've been looking for people on the list to call on you guys. So, okay, let me pull up your case list.
Okay, great. I am on call, but I think I should be okay timing wise.
Okay, let me see. Where is the case list? Here is the case list. And we have September. Okay. Did I talk to you last time? I feel like we talked recently.
I think maybe last week.
Which case list do you want to go over?
I don't care. That it is not mine.
Yours. So, I'm still thinking about Nelson. I was gonna call her. She raised her hands and then she disappeared. Okay, where's yours?
Right there, down a little. Whoop.
Oh, here you are. Sorry.
That's okay.
Which one you want to go over?
Maybe OB or office.
Let's do OB. Do you have any case on your case list that you are worried about, or should I just pick up topics randomly?
I think random topic is fine.
Okay. Let's talk about case number 4.
Okay.
Cervical insufficiency. You want to tell me a little bit, present her for a minute?
Sure. So this patient was a 32-year-old G5P1. She had a history of 1 prior term delivery, and the others were miscarriages. She came in to the office for her routine anatomy scan and was noted to be dilated on imaging, and then on cervical exam in the office was noted to be 4 to 5 centimeters. So she was sent to labor and delivery for evaluation to determine if she was having preterm labor versus cervical insufficiency. The patient had no complaints. She was seen by MFM. It was determined that she was a candidate for a rescue cerclage, which was placed the next day. Later that evening, so our MFM sent the patients home the same day. She came back with prom, and after counseling, elected for induction of labor.
Okay. Give me some risk factors for cervical insufficiency.
History of cervical insufficiency, infection, history of cervical procedures such as laceration or cold knife cone. That's what's coming to mind right now.
Okay. Let's talk about indications for cervical cerclage.
Okay, so there's history indicated, ultrasound indicated, and exam indicated. So in her case, it was exam indicated because she was dilated. History indicated would be if the patient had a history of preterm delivery with a cervical length of less than 25 millimeters. That could be a discussion as to whether they wanted a cerclage versus progesterone. Ultrasound indicated in a patient without a history would be less than 10 millimeters on ultrasound. And history indicated would be history of cervical insufficiency in a previous pregnancy, and those are typically placed earlier in pregnancy prophylactically at like 12 to 13 weeks.
Okay. What are some complications of cervical cerclage?
So complications could include bleeding, infection, rupture of membranes, could cause fetal loss because of those complications, potentially could have placental abruption if the cervix, I mean, if the placenta was close to the cervix when the stitch was being placed, preterm delivery.
Okay. What are some contraindications to cerclage?
So preterm labor, PPROM, known infection, placenta previa, I believe would be a contraindication to placing a cerclage.
Okay. Can you tell me types of cerclage?
Yes, I know that there's McDonald cerclages, Schrodkar, and then there's also abdominal cerclages.
Okay. So tell me a little bit about McDonald's cerclage. When would you place it? How do you do it? Have you done one or do you refer to MFM?
I have done them in training. I typically don't in my practice currently just because of the low volume.
Okay.
But the type that I have done in the past has been a McDonald's cerclage. This is done through a vaginal approach where there is a circumferential stitch placed in the cervix to keep the cervix closed right below the cervical vaginal junction. Typically, it's done with a permanent suture. The stitch is placed, like I said, circumferentially, kind of in a purse string fashion, with a knot to tie tied tightly to keep the cervix closed.
Okay. What about the other types of cerclage? Schrodkar. Can you tell me a little bit about Schrodkar? What do you know about it?
So I believe Schrodkar is very similar to the McDonald cerclage, except for you're excising into the vaginal or cervical mucosa, I guess, at that junction to bury the suture into the epithelium. They can be used for patients who have a really short cervical length or not enough cervix to be able to place a McDonald cerclage. I believe in cases where McDonald cerclage has failed.
Okay. And what about transabdominal or cervical isthmic cerclage? What are some indications for it? When do they do it?
I believe indications are failed Schrodkar or McDonald cerclage, so any of the vaginal cerclage placements. And those are permanent cerclages, so patients who have those placed have to be delivered by C-section.
Right. Okay. So if anybody will ask you anything about cerclages, it would be one of those questions. So let me answer them now that you answered them. I think you did good. I'll just add a couple things and I'll go over those questions that I asked you right now. So
Sure.
I asked you risk factors for cervical insufficiency. So if there is any surgical trauma to the cervix from conization, sleep, or an old OB laceration that was not repaired properly, that's one of them. There's congenital Mullerian anomalies, if there's some deficiency in cervical collagen or elastin, and this is an old one, but in utero exposure to DES, but we don't use that anymore, so we don't see that anymore, but it's just in the literature. Indications for cervical cerclage would be what you said, either history indicated, one or more second trimester pregnancy losses that are related to painless cervical dilation in the absence of labor or abruption. Exam indicated if she has painless cervical dilation in the second trimester. Ultrasound indicated if there's short cervix, less than 25 millimeter before 24 weeks in a patient with history of preterm labor and delivery, less than 34 weeks. And we usually place those as 13 to 14 weeks. Indications for cerclage are very important in the oral board exam, and it's a very common question to be asked, and it's an easy one to answer. Complications of cervical cerclage would be rupture of membranes, chorioamnionitis, cervical laceration, suture displacement, uterine rupture if she goes in labor and the cerclage is not removed, septicemia, hemorrhage in transabdominal cerclages. Contraindications to cerclage would be a short cervix, less than 25 millimeters at less than 24 weeks in the absence of history of preterm delivery, so it's not indicated. A short cervix in a twin gestation, now there's like studies that maybe you can do it in twins. Following a leap, PPROM, choreo, active labor, and abruption. And then in terms of McDonald's, use a purse string suture of non-absorbable material like morcellin. You insert it as a cervical vaginal junction through the cervical trauma, but not through the endocervical canal. And you can say, I don't do those, I refer to MFM, but I know the theory behind it, and you can tell them how it's done. Shirotkar, of course, only MFMs will do them. You do dissection of the vesicocervical mucosa to place the suture as close to the internal os as possible. The bladder and the rectum are dissected from the cervix in a cephalab manner, and the suture is placed and the mucosa is replaced over the suture, and you use a non-absorbable suture. In terms of the transabdominal cervical isthmic cerclage, it's indicated in patients who have trachelectomy or patients with failed cervical cerclage and second trimester loss. It's done through open laparotomy or laparoscopy. It can be done either in late first trimester or early second trimester or in the non-pregnant state, and those patients need to be delivered by C-section. Do you have a question on this?
No, I think that was very helpful. Thank you.
Okay, I'm going to move to somebody else because I need to get 6 people in the 90 minutes. Thank you so much for participating.
Thank you.
Okay. I'm going to mute Jennifer. And now I'm going to call on, I know a lot of you have raised your hands that I have certain names that I want to go over. And so let me hear Viscara, Nika Viscara. Are you available? Nika, I don't see you raise your hands, but are you available? I unmuted you. Hello? Okay.
Oh, hello?
Okay. Hi, Nika.
Hi.
Did I say your last name correctly?
Yes, you did.
Okay, cool. Let's go and pull up your case list. Here you are. Should we do something different than OB?
Yeah,
OB again.
maybe gynecology, actually. There's a case that
You're worried about?
yeah.
Okay, which one?
I believe it's 25. Let's see.
Okay,
Yeah.
you want to present this case for me so that I can anticipate what questions they can ask you and we can talk about what you're concerned about.
Yes. So this is a 38-year-old G5P3 who presented to the emergency room because of sudden onset pelvic pain. It had lasted for a couple of hours, and I was the gynecologist on call, and they called me in because they were concerned about ovarian erosion. So when I examined her, she definitely had just significant pelvic pain, and of the right lower quadrant specifically, and it had changed from colicky to a more constant pain that's associated with nausea. Ultrasound showed a 10-centimeter simple ovarian cyst, so I took her back for a diagnostic laparoscopy. Yeah, I ended up doing a laparoscopic right ovarian simple cyst aspiration, which I know is not standard of care, as well as adnexal detorsion for her.
Okay. So what's your concern about this case?
Well, I know that typically in the ideal setting, I would have done an ovarian cystectomy because if you do a simple cyst or a cyst aspiration, recurrence rate is about 65%, and they'll need additional surgery. So I knew that. However, because the area was extremely edematous, and I attempted to delineate the cyst wall from the ovary. However, I was concerned about bleeding, as well as the IP ligament was also extremely edematous. So I opted to perform the aspiration and counseled her that she would likely need a subsequent surgery in order to do a cystectomy in the future.
Okay, so the reason you weren't able to do the cystectomy is because you didn't think it was safe? You think she was going to bleed?
Correct.
Okay. So you did the right thing, right? You don't want her to bleed and you don't want her to lose her ovary, and you did the best that you could. You aspirated, and then after that you detorsed, and it looked okay.
Yes, it did. It was definitely extremely edematous, like I mentioned, but otherwise it looked okay.
Okay, and then you went back again. How long after did you go back again? 12
That
weeks?
was, yes, it was about probably closer to 16 weeks. I did a 12-week repeat ultrasound that showed recurrence of the ovarian cyst. It was a 9 centimeter simple cyst again.
Okay. And then you weren't able to do a cystectomy in the second procedure. You had to take out the whole ovary and the whole ovary.
Yes, yeah. So I wasn't able to get a clear delineation. I considered doing a fenestration. However, when I spoke with the patient and counseled her preoperatively, she stated that she either wanted a cystectomy or a salpingo oophorectomy.
Okay. And so you also did a left salpingectomy on her. Why?
Correct. So she also had, she desired permanent sterilization. So I counseled her on the risks, benefits, and alternatives for that. So since we were going to be doing the laparoscopic procedure already, I opted to also do her salpingectomy at that time.
Okay. I don't think you did anything wrong, and there's nothing to worry about. So if I was the examiner and I was asking you why didn't you take the cyst in the first place, and you're gonna say, I was worried that she was gonna bleed and it didn't look good, but I aspirated and then it came back. It's not ideal. It would have probably been better if she could have avoided the second surgery, but you did what you thought was good at the moment. If they ask you this question, if you would go back now that you know that this happened, would you do it differently? Would you do a right salpingo oophorectomy right then and there? Would you have been able to do that in the first procedure?
Well, I considered that. However, because the IP ligament, like I said, was also extremely edematous, I was still concerned about significant bleeding. And I was hoping that in detorsing and allowing there to be sufficient time in between the two procedures, it would allow for the edema to kind of regress and also allow some reperfusion of the ovary as well.
Okay. Okay, so that's it. That's your answer. I don't think here, if they want to ask, they'll probably ask you about ovarian cysts and how do you if they want to ask you questions other than what we just asked you on the case, they'll ask you what is the chances of recurrence, and then which you answered, right? And then they'll ask you also how would you manage ovarian cysts? Let's say if this patient had a 10-centimeter cyst that was simple, could you have left this if she didn't have torsion and just managed it expectantly, or would you have removed it? What would you have done?
If it looks simple and she hadn't had any symptoms, I would give her strict precautions for ovarian torsion, and I would follow up with another ultrasound in 8 to 12 weeks to see if it had interval decrease. And if it hadn't, then I would talk to her at that time to discuss potential surgery just to decrease the risk of torsion in the future.
Okay. If they want to ask you more questions about this, they can ask you questions about adnexal masses. So if they ask you something that's probably not related to this case, they can ask you like differential diagnosis of bilateral ovarian masses. What would you say?
I would say I could be like mature teratoma. Could just be functional cysts. Could still be either endometriomas or cystadenomas.
Okay. Let me ask you this. What is the risk of reoperation after removal of one ovary in surgery?
The
other ovary looked normal. What is the risk of reoperation?
I think it's about 30%.
So it's much less than that. It's like 7.3%, because even though the other ovary looks normal, it may still have pathology in it that doesn't show. Okay. And so just to answer that question that I just asked you about bilateral ovarian masses, so it could be teratomas, like you said, could be fibromas, could be serous carcinoma. It could be mucinous carcinoma. It could be Krukenberg. It could be endometriomas, it could be thicker lutein cysts, or it could be tubo-ovarian abscesses, because you have here mucinous cystadenoma, so they have the tendency of being bilateral in like 20% of cases.
Okay.
Okay. Let's say you have a pregnant woman who presents with like a 5-centimeter cyst. How would you manage her throughout the pregnancy? How would you counsel her?
I would counsel her that it would, that we would just keep it under observation during ultrasounds, as well as give her the precautions for torsion as well. However, just based on because of the enlarging uterus, the likelihood of torsion is less. So we would just kind of observe it at the time and kind of manage it as her symptoms arise.
Okay. So would you ever offer her surgery?
For a 5-centimeter mass, only if it was symptomatic and potentially in the second trimester, I would offer the surgery.
Okay. But if it's not symptomatic, would you leave it until she delivers?
Yes.
Even if it was like more than 5, if it was like 7 or 8 or maybe 10?
As long as it's asymptomatic.
Okay. Let's say this patient is planning for a vaginal delivery, but she has a C-section. You're doing the C-section, you're looking at it, it's so tempting, it's right in front of you. Are you going to take it out?
If we had discussed it prior to surgery, I would consider it. If it was not, if it looked like it wouldn't lead to significant hemorrhage or other complications.
Okay. It seems like you're not confident of your answers. Are you confident of your answers?
I am very nervous. This is my first one.
But you're doing so good. I promise you're doing really good. I don't know. Am I intimidating?
No, it's just it's my own anxiety.
Okay, because I try to keep it light, but sometimes I think I'm too serious. But here's the thing. So in pregnancy, you don't remove the cyst on the ovary unless you think it is cancer or you think that it's torsed. Otherwise, you just watch it. The highest chance of her having torsion is in the first trimester when her uterus is small. The bigger the uterus gets, the less chances of torsion, because the less room for the ovaries to wiggle around and move. Then eventually they become cradled by the uterus and they don't really have much room to torse. You can wait until she delivers. The only reason you are going to operate is if you think she has torsion, and you're going to counsel her about it and tell her anytime you have severe pain, you do have a big ovary and you need to come to the hospital and you might need surgery. But in some cases, a lot of cases, they might not. I actually remember I had a case in residency and I was working with the GYN onc, and she had 2 10-centimeter masses on her ovaries that we watched them all throughout her pregnancies until after she delivered. And then we did a laparoscopic surgery, me and the GYN oncologist, and we removed them then. But that is really the best way to do it. If she has a C-section, you have to fight the temptation to remove it. It is better not to remove the mass at the time of cesarean delivery because there's a risk of significant blood loss due to the engorged local vasculature. She might require a complete salpingo oophorectomy because there might be a lot of bleeding if you try to dissect it off, and she's gonna lose her. If you do it postpartum, there is a chance, if the cyst is not too big and taking all the ovary, that there's a chance that you might be able to save this ovary in a woman who probably wants to have more kids and wants her ovaries, right? And so the operation postpartum will probably permit an ovarian cystectomy with ovarian preservation and less operative risk versus if you do it at the time of the C-section.
Okay.
Does that make sense?
Yes, thank you.
Okay. Also, do you know what the most common adnexal masses in pregnancy are?
Yeah. Sorry, I'm blanking right now. I believe a
Cancer,
dirt.
cancer is very rare. The most is like 1 in 10,000. The most common would be like mature teratomas or paratubal cysts or corpus luteum cysts.
Mhm.
If she has malignancy, it will be probably a germ cell tumor, a stromal tumor, or epithelial tumor of low malignant potential. What are some things that decrease the risk of ovarian cancer?
Things that decrease risk of ovarian cancer would be multiparity, later age menarche, use of oral contraceptive pills for at least 5 years,
Okay, good.
earlier menopause.
Okay. So more than 5 years use of birth control pills, pregnancy less than age 25, decreased by age 30, lactation, tubal ligation, BSO, all decrease the risk of ovarian cancers. What are some risks for ovarian cancer?
Risk of ovarian cancer would include family history of ovarian cancer, if they are positive for BRCA1 or 2, nulliparity, early menarche, late menopause. Yes, those are what I have on top of my head right now.
Okay, so age is the most important risk factor. BRCA1 increases the risk 60-fold. BRCA2 increases the risk 30-fold. Lynch2 increases the risk 13-fold. Nulliparity, endometriosis, primary infertility, and the woman's lifetime risk of developing ovarian cancer is about 1 in 70. Last question, and I'll let you go. What are some ultrasound findings of benign and malignant adnexal masses?
So for benign masses on ultrasound, a simple cyst, no, sorry, let me start over. For benign masses on ultrasound, you would look for a simple cyst, size less than 10 centimeters, no thickened septations or solid excrescences or solid areas, a thinner border. Let me see. I think those are the main ones.
So benign disease would be like unilocular mass, thin-walled, cleared with smooth, regular borders. And for malignant masses, they would have like solid components, septations, mural nodules, excrescences, and the patient would have other stuff like ascites, and like bilateral masses is more concerning as well. Okay, thank you so much for participating. I hope this was helpful.
It was, definitely. Thank you.
Okay, sure. Okay, let's do Sarah Mufarraji.
Yes, hi.
Hi, Sarah.
Hi, how are you?
Good. Have we talked before?
I think so.
Okay. Let me just mute Mika. Okay. Okay, Sarah, let me pull up your case list. Are you ready?
Yes.
Okay. Where is it? Here it is. Which one?
Could we do office?
Yes.
I know some people had wanted to do osteoporosis previously. I have quite a few of those.
Okay, good. Let's do those. Which ones are the osteoporosis ones?
Or osteopenia. I think case 3 and 1.
Presenter, and then I'll ask you about osteoporosis. Can you present case 3, Sarah?
Yes, sorry. Can you hear me?
I can.
Okay. Case 3. So yes, this was a 76-year-old who had a history of a ovarian cyst that was being monitored with serial ultrasounds. Her findings on ultrasound were not concerning for malignancy due to the small size and unilocular nature. So she came to us for evaluation. We performed an ultrasound with the findings I just discussed, and tumor marker was CA-125, which was normal. Given these normal findings, we also decided to do a healthcare maintenance visit for her. So we performed a DEXA scan for her history of osteopenia. And she was found to have a T-score of less than -1. So we counseled her on diet and exercise with vitamin D and vitamin C supplementation, mainly through food, and weight-bearing exercises that I just discussed, and follow-up DEXA scan in about 2 years.
Okay. So let me ask you a little bit about osteoporosis. What is the FRAX score?
Yes, so the FRAX score is a screening tool that is used for patients that are usually above the age of 40 that predict the risk for a fracture in the next 10 years. And it has different subsets. It includes age, sex, BMI, a history of a previous fragility fracture, a family history of a hip fracture, whether they are smokers, whether they use alcohol, corticosteroid use is on there too, whether they have rheumatoid arthritis, and basically calculates their risk for developing a hip fracture or a major fracture. And it's basically used to guide the healthcare providers as to when to perform a DEXA scan or when to treat patients with osteopenia.
Okay. What is the definition of T-score and Z-score?
So the T-score is basically the standard deviation that takes into account the mean peak bone density of a normal young adult, so not postmenopausal. And then the Z-score is also a standard deviation that actually includes a patient of the same sex and age and race as the patient that's being evaluated.
Okay. What are some conditions and diseases that can cause osteoporosis?
So alcoholism can cause it, rheumatoid arthritis, patients who have hyperparathyroidism, patients who have history of gastric bypass surgery, patients with vitamin D deficiency, of course, patients who have poor oral intake like anorexia, diabetics, patients with AIDS or HIV, so immunocompromised, menopausal patients in general. And then there are a lot of drugs that can also cause it.
What are the medications that can cause osteoporosis?
Yes, so as I previously mentioned, steroids are one of the most common ones. We also have aromatase inhibitors, Depo-Provera, but that's reversible, anticonvulsants, antiepileptics, lithium, heparin, TPN, chemo, and I believe some antiretrovirals as well.
Okay. So if you want to treat somebody for osteoporosis, what medications would you give?
So the first line medication would be a bisphosphonate, like zoledronic acid. We can also opt for HRT or SERM, like raloxifene. There's also calcitonin. And then you have the option of also doing a rank ligand inhibitor or parathyroid hormone. And then there's a last one, this sclerostin inhibitor, I think it's called.
Okay. And so what are the doses? What medication is your favorite and what doses?
So in terms of favor, I think the most efficacious and first line would be the bisphosphonate. So zoledronic acid can be given orally or, zoledronic acid is only given IV. And I think it's 4 milligrams. I think it's yearly. There's also bisphosphonate that can be given orally, but I forgot what it's called. Calcitonin, I know, is given 200 international units daily as a nasal spray or sub-Q.
You're telling me all of them, but I just want to know the one that you prefer to give.
Sorry. Yeah, zoledronic acid, I think 4 milligrams IV.
Okay. And so what are some side effects of giving zoledronic acid?
Some side effects could be, well, the most dangerous side effects are osteonecrosis of the jaw and an atypical femur fracture. And I think very, very rarely it can cause esophageal cancer.
Okay. And what are other medications that you would prefer to give other than the IV medication? Is that your first line that you would like to give, the IV medication?
You can also do oral.
Oh, so which one?
I forgot the name.
Would you give like alendronate or ibandronate? You know, alendronate, fosamax?
Mm-hmm. I just don't remember the dose.
Okay. And so it's okay if you don't remember the dose, as long as you know the medication and who not to give it to.
Mm-hmm.
Okay. And so for those medications, for the other bisphosphonates, what are some contraindications to giving them?
Yeah, the most common contraindication is renal failure. So you have to make sure you check their GFR and creatinine. Patients also with hypocalcemia are not allowed to get bisphosphonates. And then any patients that have esophageal motility issues like achalasia will also be poor candidates for this medication.
Okay. What about like raloxifene or Prolia, denosumab? Do you give those? Have you given those before?
I've given Prolia before. It's sub-Q every 6 months. I also forgot the dose, so I'm sorry. The contraindication is similar to the bisphosphonate. We don't give it in patients that have hypocalcemia, but it can be given to patients that have kidney dysfunctions. And then raloxifene is ideal for patients that have concomitant breast cancer and who are postmenopausal. But I also forgot the dose.
Okay. It's okay if you forget the doses. You don't have to remember all of them. As long as you know what the medication is and what are the contraindications, you're good, because you probably don't give all of them. And really, ideally, in real life, what we do is that we search the doses when you want to give the medications.
Mm-hmm.
As long as you know when you counsel the patients what medication you're going to give and who not to give it to, that's the important thing in the exam. What about raloxifene?
Yes, so raloxifene, so as I mentioned, it's ideally given to patients that also have breast cancer, since it's an estrogen receptor modulator, so antagonist in the breast and agonist on the bone. So for these patients, I do counsel them that they might be at increased risk of thrombotic events and vasomotor symptoms. But I think the main contraindication for raloxifene would be patients that have an active VTE or liver dysfunction.
Okay, and then the other two, you mentioned them, calcitonin and parathyroid hormone. As long as you know a little bit about each one of them, the most important one is the bisphosphonate and raloxifene and Prolia and the zoledronic acid that you mentioned, because each one of them is given in a different route. So the bisphosphonates are given PO, the zoledronic acid is given IV, and then Prolia is very convenient in that you can give it sub-Q every 6 months, so you don't have to worry about taking it daily or bi-weekly, just like zoledronic acid, which you get it like once every year for the treatment and once every 2 years for the prevention. Okay, so let's say you have a patient and you are treating her with any of those medications, and then how often do you follow up with a DEXA scan to see the improvement in the treatment?
Yeah, I think that there are no set guidelines on that, but usually we will repeat the DEXA scan every 2 years, unless there is a reason to repeat it earlier, whether the patient had a new risk factors such as increased use of steroids or a new autoimmune disease that might warrant earlier screening because of possibility for worsening bone mineral density. But other than that, it would be every 2 years.
Okay, so let's say you did it every 2 years, or this is the first time you're doing it 2 years after treatment, and you're looking and her bone mineral density has not improved. What would you be thinking?
So is it osteopenia or osteoporosis?
It's osteopenia.
Okay, so if it doesn't improve, then I would make sure that she is performing the conservative measurements, which are weight-bearing exercises and increased intake of vitamin D and calcium, mainly through food and not just supplementation. And if she has been doing all these things and there is no improvement, then I would perform a FRAX. And then if her FRAX score is greater than 3% for the hip fracture risk or 20% for a major fracture, then she would warrant treatment.
Okay, but did you understand the question? You're already treating her.
Oh,
And
sorry, with medication?
Yeah, you're already treating her, but she's not improving. Like she's still, like the medication is not working. So what would you think if her bone mineral density is not improving after 2 years when you're repeating the DEXA?
So I would go over all of her medications, risk factors, medical history to see if there's any new risk factor that could be contributing to this. So like smoking, alcohol, use of steroids. And then I would probably switch her medication. So if I were starting with a bisphosphonate that wasn't working, then I would probably switch to maybe the parathyroid hormone.
Okay, so I'm going to stop here for a minute. And so if you're managing a patient and her bone mineral density is not improving during treatment, and there might be a couple reasons. It might be that the patient is not compliant. There might there are secondary causes that we probably haven't investigated thoroughly. Check for vitamin D level. Also, does the patient have any GI problem like gastric bypass or irritable bowel disease that's preventing the absorption of the medication, so it's not really giving the effect that it should give? What are some secondary causes of osteoporosis that you would be evaluating for if you thought that was the cause?
So like we mentioned, so gastric bypass, vitamin D deficiency, hyperparathyroidism, hypocalcemia.
Yeah, so you would do like a CBC, a metabolic profile. You would do a 24-hour urinary calcium level to rule out parathyroid disease, which could be also something that is causing her not to improve. You do a vitamin D level. You do a thyroid test, a TSH. You can also order a celiac panel to look for GI disease and serum protein electrophoresis for multiple myeloma.
Okay.
Going back on the questions that I asked you, we talked about the FRAX score. It's an assessment tool that is developed to predict the risk of fracture in the next 10 years, only valid for women age 40 and older. The risk factors are age, sex, BMI, previous fragility fracture, parental hip fracture, current smoking, alcohol more than 3 drinks per day, steroid use more than 5 milligrams per day for 3 months, rheumatoid arthritis, and other secondary causes. The FRAX score, what is the percentage above which you do DEXA and above which you start bisphosphonates?
Yes, so if they have osteopenia, the FRAX score would have to be greater than 3% for the hip fracture and then 20% for major fracture.
Yes, and that's when you would start treatments. What if it's more than 8.4?
That is the number I would use to perform a DEXA scan on a patient that's less than 65, which is usually the age at which you start DEXA scans.
Correct. And so we're talking about, the next question was about conditions or diseases that cause osteoporosis. So you think about it like by system. So if it's endocrine, then it could be like diabetes or thyrotoxicosis. You think about different systems. If it's GI, it could be irritable bowel disease. We just talked about gastric bypass and celiac disease. If it's genetic, then it could be like cystic fibrosis, osteogenesis imperfecta. If it's hematologic, it could be hemophilia, sickle cell disease, or multiple myeloma. It could be like some lifestyle stuff like decreased calcium intake, smoking, immobilization, thinness, or it could be like some medications, and we're going to go over the medications. There are also other stuff like premature ovarian failure and anorexia and other stuff. If you memorize them by system, then you remember like 2 of each. Like you remember 2 from the GI, 2 from the endocrine, 2 from the hematologic, then you got more than 5, then you're good. So the more you bunch the diseases and stuff together in a way to memorize, the easier it comes in the exam. And then in terms of medications, and so I have a way of memorizing them. So I do them alphabetically. So A for anticoagulants like heparin, anticonvulsants, and aromatase inhibitors, 3 A's. B for barbiturates. C is for chemotherapeutic drugs. D is for depot. G is for glucocorticoids or GnRH agonists, and L is for lithium.
Nice.
Okay. And like then we talked about medications. I'm not going to go to a lot of detail because you did okay. So the 4 drugs that are bisphosphonates: alendronate, risendronate, ibandronate, and zolendronate. The alendronate is the Fosamax, ibandronate is Boniva. Those are the 2 that most of us prescribe. Pick one that you are going to talk about in the exam and try to remember the dose. So like alendronate is easy, 5 milligrams per day for prevention, 10 milligrams per day for treatment, or you can give it weekly, either 35 per week or 70 per week for prevention and treatment. And then in terms of side effects and contraindications of bisphosphonate, you mentioned if there is inability to stay upright for 30 minutes, or there's hypersensitivity, or patient has increased risk of aspiration, those would be some of the contraindications. Side effects would be also like osteonecrosis of the jaw or atypical fracture of the femur shaft. And then there is Prolia or denosumab, that's a rank ligand inhibitor. And that one, the contraindication you mentioned is hypocalcemia. It is given sub-Q 60 milligrams every 6 months. Remember, 60 with 6 months makes it easier to remember if you want to remember the dose. Raloxifene is good for women who are in the perimenopause. It is good for prevention and treatment of osteoporosis. It also decreases the risk of invasive breast cancer in postmenopausal women at risk. So it's good for those women at increased risk of breast cancer. The contraindication would be like stroke or DVT. You don't want to give it to those patients because there's increased risk of thromboembolic events with it. And then the rest, those like calcitonin and parathyroid, I doubt they'll ask you a lot of questions about them. You mentioned zoledronic acid. It's 5 milligrams every 2 years for prevention and every 1 year for treatment. And the contraindications would be hypocalcemia and renal disease. I can ask more questions about osteoporosis, but let's stop here because I want to get somebody else. Maybe one day we can make a structured case out of it. I want to go back to the questions, and the reason you saw me searching the web while you were answering questions about osteoporosis is that Yu-Chen asked me a question: is there a role in vaginal progesterone in the first trimester for recurrent pregnancy losses? And I know that there isn't, but I wanted to make sure that I'm not missing on anything. So only if they have low progesterone levels, and a lot of people give it just prophylactically. We don't really know if it's really effective, but if they test her progesterone level and it's low, then it's probably like a good idea to give it to help support her throughout the first trimester. And then I have another question here. What is the percentage risk of reoperation for the second ovary once the ovary has been operated on? I just mentioned that when I was asking Sarah. It's 7.3, and it's because the other ovary might have pathology, might look normal, but might have some pathology. But it also varies depending on what the condition is. Did you take the ovary because she has endometriosis? Did you take it because it has something else? So it's kind of like general. So those are the questions that I have. I'm gonna ask somebody else. If anybody has questions, please put them in the questions and I will look at them in between the mocks and answer them. Okay, thank you so much for participating. Sarah, I appreciate it. Do you have any questions before I let you go?
No, so you just recommend in terms of doses, it's okay to just know one of the medications, because I do have a lot of osteoporosis on my
Yeah, you said you use zoledronic acid. Know the dose for that. It's very easy.
Mhm.
But then I think you should know the bisphosphonates as well, because a lot of people give PO medications. They don't give IV. Why? What is the reason you give IV? Sorry, I said ID. What is the IV?
Most of the patients that I'm treating are cancer patients that are also coming in for either chemo or they're coming in for other aromatase inhibitor treatments. So it's just more convenient for them to get treated in the clinic. So it gets done all at once, IV.
Oh, okay. So that makes sense. But I think you should memorize like the roloxifene, just a little bit what I mentioned, contraindication. You don't have to know the dose if you don't give it, but you have to know like roloxifene is good to give it to women who have like increased risk of breast cancer. It's contraindicated in women who have clots. Like you need to know those things in
Mhm.
general. And I know I'm encroaching on other people's time because I need to get 6 people in the hour and a half. Postmenopausal women in their 50s, the best is to do either roloxifene or you can start bisphosphonates. In their 60s, the best thing is to start bisphosphonates. People who have GI problems or adherence issues, zoledronic acid is the best. People with high risks of fractures, Prolia is the best.
Mhm.
You can't put them on bisphosphonates for more than 10 years. So if you're starting them in their 50s, it's better to start a SERM and then switch them to bisphosphonates.
Mhm. Thank you.
Okay, sure. Okay, I'm going to mute Sarah and I'm going to call on Stella or Nora. Stella? Hello? Stella? Okay. Let's go back here and let's see. Second call. Sorry, I'm gonna turn this off. Okay. I'm looking at here. I have Nelson. Corinne Nelson. Corinne, I'm gonna unmute you. Hello?
Hi,
Are you available?
I am. Sorry. I don't know why it tends to like take away my hand. I don't know how to fix that.
That's okay. Let me log back in because I think I logged out. How are you doing? Which case list do you want to go through?
Any of them I think would be good.
Okay, just give me a minute so I can pull up the case list.
Okay.
I closed it by mistake. How is studying going? When is your exam?
Studying's going okay. It's getting a lot. My exam is in October. It's October, the week of the 23rd through the 26th. So hopefully find out the day here soon.
Okay. And how is studying?
It's going fine. I'm just ready for this test to be over.
Okay. So can you see the lists?
Yep.
Okay. So Nelson. I know I wanted to call you at the beginning.
Yeah, I did. I tried to say I was here, but I wouldn't let me unmute. I'm not sure what happened there.
Okay. So you don't care anyone? Let's do OB.
Okay.
Okay. What are you, general? Oh, you're a fellow. What kind
I'm
of fellow?
I'm an MFM fellow, but I honestly really haven't done that much practice with my OB lifts
Oh,
because I've been focusing so much on the gyne in the office. So it'd be nice to at least practice one.
okay. Tell me some risks associated with AMA, since I just saw AMA while I looked through your case list.
So risks associated with advanced maternal age include both maternal and fetal risks. I talked to patients about the increased risk for development of pregnancy-related hypertensive issues such as preeclampsia, gestational diabetes, need for cesarean section, and associated hemorrhage. Fetal risk can include most commonly fetal aneuploidies. Increased risk for stillbirth, particularly when women who are over 40, and increased risk for growth restriction as well.
Okay. What are some risks associated with teenage pregnancy?
Yes, so increased risks for teenage pregnancies. When I talk to patients about that, I also talk about maternal and fetal risks. Maternal risks include increased risks of PPROM, increased risk for, if it's their first pregnancy, increased risk for pregnancy-related hypertensive issues, as well as potentially gestational diabetes. Some fetal risks include increased risk for preterm deliveries, increased risk for placental abruption, and increased risks for growth-restricted fetuses.
Okay. Did they go over postpartum hemorrhage recently with you in the webinar?
I think we have. I can't remember how recent it has been, but I know that we've done it.
How about we talk about placenta, like you have placenta previa here and accreta. How about we talk about that?
Okay.
Let me just go over real fast. So risks associated with AMA, GDM, preeclampsia, IUGR, stillbirth, increased cesarean delivery, increased preterm delivery, increased risk of aneuploidy, increased risk of postpartum hemorrhage, and also increased risk of abnormal placentation. And in terms of teen pregnancy, though, there's an increased risk of immaturity, poor social support, poor prenatal care. There's also increased incidence of preterm delivery, preeclampsia. A lot of those teenage girls, they smoke, they have drug problems. And so those are some risks that are associated with teen pregnancy. They like to ask those questions about teen pregnancy and advanced maternal age in the exam. Let's talk a little bit about placenta previa. So what are some risk factors for placenta previa?
Risk factors for placenta previa include history of previous pregnancy affected by placenta previa, uterine anomalies would increase risks for placenta previa, history of uterine surgeries such as history of cesarean delivery, increase the risk of placenta previas.
Okay, and how would you diagnose, I'm sorry, not that's an accreta. When would you deliver somebody with placenta previa?
I would deliver somebody with placenta previa between 36 and 0 and 37 and 0 weeks.
Okay, and what are some risk factors for accreta?
Risk factors for placenta accreta include not history of, but placenta previa increase your risk of placenta accreta spectrum. It's the main risk factor, one of the main risk factors, as well as a history of uterine surgery such as cesarean delivery.
Okay. What is the risk of accreta in relation to the number of C-sections and previa?
The risk of accreta will increase with subsequent will increase with subsequent cesarean deliveries and in the presence of placenta previa.
What is the percentages? What are the percentages?
The percentages are for a history of 1 prior C-section and placenta previa, it is 3%. 2 C-sections is approximately 10%. 3 C-sections jumps up to approximately 30 to 40%. 4 C-sections, 4 C-sections is also approximately 40%, and 5 is around 60+%.
What is the difference between increta, percreta, and accreta?
So accreta is the placenta invading into the wall of the myometrium. Increta is when the placenta invades through the wall of the myometrium, and percreta is when an abutting adjacent organ such as the bladder. Percreta is when the placenta is grossly invading other structures such as the bladder.
Okay. And what are some ultrasound findings that support the diagnosis of accreta?
Ultrasound markers that support the diagnosis of accreta would include placenta lacunae, loss of the myometrial or loss of the uterine placental interface, increased vascularity at that interface, but placenta in presence of placenta lacunae is one of the strongest markers.
Okay. And so what is the average blood loss in a patient who has accreta?
I am not sure of that exact number off the top of my head, but I would guess that it would be somewhere between 1 to 2 liters, depending on the case.
Okay. What is the mortality rate?
In patients with a known diagnosed placenta accreta spectrum disorder?
Correct.
Approximately 10%.
Okay. And how would you deliver this patient with accreta? What would be the plan?
So my plan for this patient would be a repeat cesarean delivery with concurrent hysterectomy.
Okay. And so at what gestational age would you do that?
Typically, but there is a range that you can deliver these patients at. Typically, I recommend delivery at approximately 35 weeks.
Okay. What about other conditions that are related to placenta accreta? I mean, let's talk about this. Would you consider not doing a hysterectomy and taking the baby out, leaving the accreta, and probably give methergin or giving methergin afterwards? As some, I've read somewhere that you can do that. Have you done that? Have you considered that?
I have not personally done that, and that is not something that we offer at our institution. I do know that it exists in the literature, and there are some institutions that offer that.
Okay, but the risk is high. I mean, she
The
might.
risk, the risk is, I know the risk is higher for patients requiring, for patients needing increased blood products, for patients requiring, delayed hysterectomy. And so there are definitely certain parameters that those patients have to meet in order to even be considered candidates, to the best of my knowledge. But that's something that we offer at our institution.
They do that for patients who really don't want to lose their uterus, and they want to try to salvage their uterus. And I don't know if I said methergin, but it's methotrexate.
Yeah.
Methotrexate. Okay. Let's talk a little bit about placental disease in general. Let's talk about conditions associated with vasoprevia. What would you do in a patient who has vasoprevia? How would you manage her?
Yeah. So for a patient who has a known vasoprevia, I would discuss the diagnosis with her. We at our institution offer repeat ultrasound for evaluation of the vasa previa throughout the pregnancy. If it is still present between 30 and 32 weeks, we talk to the patient about the potential for inpatient admission and monitoring throughout the remainder of the pregnancy throughout until delivery.
Okay. And when would you deliver?
Again, there is a range with these patients, and I talk to them about the risk benefits of that range, and typically recommend delivery somewhere between 34 and 35 weeks for these patients.
So in Pearls of Excellence, they say that you hospitalize at 30 to 32 until delivery, and then you do an elective cesarean delivery at around 35 weeks with a prior course of steroids with no need for fetal lung maturity. And so for the percentages of the accreta, I have to look at those because I forget them too. So in relation to C-section, one C-section, 0.2% chance of accreta, 2 C-sections, 0.3% chance of accreta, 3 C-sections, 0.6, 4, 2.1, 5, 2.3, up to 6 C-sections, and the chance of accreta is 7.7. If there is a previa in relation to the current previa and C-section, if there's a previa and a C-section, then the percentages go really high. So previa with previous 1 C-section, chance of accreta is 3%. Previa with 2 C-sections, chance of accreta is 11%. And previa with 3 C-sections, chance of accreta is 40%. 4 C-sections with a previous 61%, and 5 C-sections, the percentage is 67%. The amount of blood loss is around 3,000 to 5,000 in an accreta, depending on what happens in the surgery and whether you're going to try to take it out or not. I don't know why this is happening. And also the mortality is 7%.
Okay.
I think you did good with the answers, so I'm not going to go over the stuff that I asked you because I want to have time to call other people.
Mm-hmm.
Thank you so much for participating.
Thank you.
Okay. Okay, I'm going to mute Corinne. And then I have 2 people here, and Ankita Raman. And Ankita,
Hello.
would you like to participate?
Yes.
Okay, cool. Let me pull up your case list. Which case list you want to go over? Where is
You
it?
could choose any.
Where is it? You see it? Oh, here it is.
Right there. Yeah.
Okay. You want to do office again or OB again? It's up to you. Let's do office.
Any is fine. Yeah.
Okay, let's do office. Is there anything that you're concerned about in your office case list?
No, I would let you choose.
Okay. Here we talked about, let's talk about PCOS.
Okay.
So you have here, this patient is PCOS or is it hirsutism? Which one is its case for PCOS?
It is PCOS. Yeah.
So tell me how you diagnose PCOS.
So polycystic ovarian syndrome diagnosis is based on Rotterdam criteria. So I do first take history from a patient, see if they have any symptoms of anovulation. So if they have oligomenorrhea, amenorrhea, and then I do a physical exam as well to see if they have any signs of hyperandrogenism. That would be the second in the Rotterdam criteria, or if the lab shows any signs of increased androgen levels. And then third criteria in the Rotterdam criteria is polycystic ovaries on the ultrasound. So if the patient has 2 out of 3 positive, then, and obviously we want to rule out other etiologies, then yes, that makes a diagnosis of PCOS.
Okay. What about hirsutism? How do you differentiate? What is your causes and differential diagnosis of hirsutism?
So some of the differential for hirsutism would be, one would be familial hirsutism, PCOS, It could be Cushing's disease, non-classic congenital adrenal hyperplasia, androgen-secreting tumors. Those are some of the things that's coming to my mind right now.
How do you differentiate hirsutism from virilization?
So hirsutism would be a virilization would include other things like deepening of voice, acne, external genitalia, could show, like clitoromegaly, and hirsutism is just increased hair growth in abnormal areas.
Okay. Can you tell me a little bit about the Ferryman-Galloway score for hirsutism?
I'm aware of the score, but the details I'll have to review. I know that the score includes hair on the chin, hair on the upper lip, hair on the front, in the chest area, and in more severe cases, there is hair in the back area too. But the exact scoring I'll have to review.
Okay. What hirsutism labs would you order?
If I'm concerned about hirsutism, or I'm assessing for hirsutism, then the labs I would get would be total and free testosterone, DHEAS, 17-hydroxyprogesterone. If there is concern for Cushing's disease, and I would also get a 24-hour urinary free cortisol. That's where I would start.
Okay. So what would be your treatment options?
So for hirsutism, if the patient, if I identify the cause, like say if the patient has Cushing's, and I would refer her to endocrinologist for proper treatment. But if it's hirsutism due to PCOS or familial hirsutism, so then some of the treatment options would be first, if she's obese, then I would recommend weight loss, because weight loss by itself, by decreasing sex hormone binding globulin, can decrease free androgen levels and decrease hirsutism. The other option could be oral contraceptive pills that also functions in the same way by decreasing sex hormone binding globulin. Some anti-androgen medications that I can prescribe would be spironolactone, finasteride, flutamide, and then also hair removal methods. So laser hair removal, or there's this medication, eflornithine, which is also used for hair removal.
Okay. How does spironolactone help with hirsutism?
Spironolactone is an androgen receptor antagonist, and it also is a 5-alpha reductase inhibitor.
Okay. Let's go a little bit over hirsutism. And so you talked about the diagnostic criteria for PCOS, hyperandrogenism, oligoamenorrhea, or PCOS on ultrasound. You need 2 out of 3. Those are the Rotterdam criteria. There is also the NIH criteria, both required hyperandrogenism and oligoamenorrhea. And then there is the AES criteria, hyperandrogenism, plus 1 of 2, either oligoamenorrhea or PCOS by ultrasound. And then I asked you causes and differential diagnosis of hirsutism. So it could be familial, it could be PCOS, it could be congenital adrenal hyperplasia, it could be tumors, ovary or adrenal, it could be some drugs like adenosole or androgen. I also asked you how to differentiate hirsutism from virilization. So hirsutism is just normal scalp hair with acne, facial hair, and acanthosis nigricans, but virilization is the same with deepening of the voice, temporal balding, clitoromegaly, and so on. The Ferryman-Galloway score for hirsutism, you don't have to know it exactly because it's usually printed on a piece of paper, and we usually just score it on the piece of paper. So you have to know that if it's more than 8, then it is abnormal. So 8 to 15 is mild, 16 to 25 is moderate, and more than 25 is severe. What labs to order? You would order a testosterone. If it's less than 150, it's probably PCOS. If the testosterone is more than 150, then it's probably a tumor. You want to order an ultrasound or CT. You order DHEAS. If it's more than 700, it's elevated, you think it might be an adrenal tumor. You also can order 17-hydroxyprogesterone. And then you should also order on those patients like prolactin, TSH, and 24-hour urinary-free cortisol to look for all the reasons that could be cause of hirsutism. And then treatments could be like birth control pills, NuvaRing, spironolactone, flutamide, eflornithine, laser, any of those treatments. They can ask you about them. In terms of birth control pills, which one would you give if you're going to give?
So I usually prescribe Yasmin because it has drospirenol, which is an anti-androgen.
Okay, yes, so it's important to get one that has drospirenone. And then spironolactone is also one of the options. You give it like 50 to 200 milligrams daily in 2 doses. Some of the side effects is that it can cause hyperkalemia. The spironolactone, I asked you how it works. It blocks the androgen receptors. It also decreases testosterone production, and it's useful for patients with hypertension or edema for 6 months to 12 months before effects are noticeable. It's also it's some of the side effects that you want to tell the patients about. It causes drowsiness, heartburn, and it causes some GI upset. So those are some things that they could ask you about hirsutism. I just picked to talk about that because I thought like it's probably less asked in the exam, but it's also an important topic that could be asked about. I'm looking here. I see some people are sending me some messages. I'll address them at the end of the webinar about, I think, the percentage of Previa. I'll address it at the end. But I want to call one more person. Thank you so much for participating.
Thank you.
Okay. Let me mute you. And then I was going to call here Erlene. Hello, Erlene. Okay, she's not answering. I'm going to mute her. And I'm actually going to call on Emily. Hi, Emily.
Hi.
Hi, how are you?
Good. How are you?
I know you've been sending me this message that I said it wrong, the percentage.
Yeah, I just wanted to clarify because I thought you said that with one prior C-section and a previa, there's a 3% risk of accreta, and I thought that was with no prior sections. So I just checked ACOG, and I just wanted to give you the information that I found.
Thank you for correcting me. I read here you wrote, I thought the baseline risk with no prior C-section and previa is 3% and one prior C-section is 11%. Please let me know if that is incorrect. No, I think you are right. I think I was just saying it quickly and I said it incorrectly, and I apologize for that. I'm sorry.
No problem. So other people have said that to me before, so I really was trying to just make sure I hadn't learned it wrong.
Thank you, you guys. Like I sometimes, if I say something that is not correct, please correct me. And so you're not the only one. Elisa also sent me a message saying that the 3% risk of accreta is not if they had a previous C-section. Okay, thank you for correcting me. I'm sorry I said it wrong.
No problem.
Okay, which case list do you want to go over?
Oh, I think I could use some work with Office if that works.
Yeah, anything. Let's go. Do you see your case list? Schneider, your last name?
Schneider, yeah, I sent it a while ago.
Should be
I don't
here.
see it. I started the webinars back in August though, so I don't know.
Oh, no, let me go back in August and pull it from August. Because we have case lists in each month. Let me go back. Case lists, August. Do you see yours?
No, I don't see it. I don't know if they didn't upload it.
Do you have a topic you want to talk about? We have like 10 minutes. Just tell me what the topic is and I'll ask you questions. Or if you have a case, you want to present it and I'll ask you questions about it.
Sure. Could we go over emergency contraception?
Sure. Let's talk about emergency contraception. Tell me what you would use for emergency contraception.
So I guess depending on how long it's been since the patient had unprotected intercourse, I would see if she would like a long-acting method of contraception, in which case I would counsel her about copper IUD, potentially levonorgestrel IUD, I think based on more recent kind of studies that are coming out. But if she was not interested in having a LARC method, then I would opt for ulipristal acetate.
Okay. And how do you give that? And how do you counsel the patients about that?
The Ella, or the ulipristal acetate, is a one-time pill. I believe it's a 30 milligram dose that the patient takes one time. I counsel the patient that this type of emergency contraception is very effective, even if it has been up to 5 days since they had unprotected intercourse. And that typically, because it's not hormonal treatment, the side effects are limited. I think it's very safe. It shouldn't affect any future fertility. And that's really it.
Okay. Let's talk about like copper IUD. How does it work in preventing pregnancy?
It creates an inflammatory kind of environment that prevents fertilization of the egg by the sperm. And I believe it also has some effect on preventing implantation of an embryo into the endometrium as well.
Okay. What is the mechanism of action of the Mirena IUD?
The Mirena IUD is levonorgestrel, and it acts by causing atrophy of the endometrium, so also preventing implantation of an embryo, as well as by thickening cervical mucus, which can decrease sperm transport. And I think it also potentially can suppress ovulation, but it doesn't do that in all patients. And I think that typically that may take up to a year to see an ovulation occur.
What are some types of levonorgestrel IUDs?
There's the Mirena IUD, which is a 52 milligram IUD, and that the dosage really confers how long that the IUD is effective for contraception. So the Mirena IUD, I believe, is FDA approved for 5 years, but it can be effective, I think, even up to 7. And there is something called the Skyla. I think it's approximately 37 milligrams of levonorgestrel, and it is FDA approved for 3 years. And then there's also the Liletta, which is also 52 milligrams of levonorgestrel and works similarly to the Mirena, just in a generic form.
Ask you what are the benefits or indications for using either the copper or the Mirena IUD, what would you say?
So in terms of emergency, or also for long-acting contraception?
For long-acting in general, like what would be the benefits of using Mirena or copper IUD?
Sure. So I usually start with a blanket statement that the Mirena is a hormonal IUD that contains a progestin, and that the copper IUD does not contain any hormones. I then talk to the patient about what their menstrual cycles are like, and if they typically have heavy, painful periods, I counsel them away from use of copper containing IUD. The reason being that it can cause heavy periods, it can cause increased dysmenorrhea, as opposed to the levonorgestrel IUD, which can improve bleeding as well as dysmenorrhea symptoms. I guess the benefit of the copper IUD being that it has a longer efficacy, so it can be used for 10 to 12 years.
Okay. Contraindications to IUDs.
So contraindication to copper containing IUD would be things like Wilson's disease or copper allergy. Otherwise, I believe that active PID is also a contraindication to IUD placement. And it's not a contraindication, but there's an increased risk of expulsion if the patient has large fibroids. I think that's it that I can think of.
Okay. What are some complications of IUDs?
Well, expulsion is one of the possible complications, that it can fall out of the cervix, especially if it's placed post-placental. Other complications are malpositioning. So if it can come down into the lower uterine segment or into the cervical canal, especially with the copper IUD, then the efficacy of the IUD is decreased for preventing pregnancy. It can also perforate through into the myometrium and rarely through into the peritoneal cavity. And other possible complications are pain at the time of placement, and possibly losing the strings, which can make removal more difficult.
Okay. Let's say you have a pregnancy with IUD in situ. How would you counsel the patient about that?
If the patient, assuming this is an intrauterine pregnancy, or are we not sure of that yet?
It's an intrauterine pregnancy.
Okay. So if there was an intrauterine pregnancy with an IUD in place, the first thing I would do is try to visualize the IUD. And if it were in the cervical canal, or if I could visualize the strings, I would counsel the patient that I would recommend attempting to remove it, because there can be adverse pregnancy consequences with an IUD in place. If I couldn't visualize the strings and the IUD was clearly in the endometrial cavity on ultrasound, I would counsel the patient that the IUD should stay in place if it's a desired pregnancy, and that there's an increased risk of things like spontaneous abortion, preterm delivery, and intrauterine infection.
Okay. And so let me go over some of the stuff that we just talked about. I think you did very good in all of your answers. Why did you want to talk about emergency contraception?
I just feel a little shaky on the office section in general.
Yeah, so I think you did good. You can also, other than using the copper IUD, you can, and the olipristal that you talked about, you can also use combined birth control pills. Do you know how to, if the patient doesn't want to buy it and she has pills at home, how can she use the birth control pills for contraception, for emergency contraception?
Yeah, I don't remember exactly what you tell them to take, but I think it's something like 3 pills at a time.
So she
At one
needs,
time, yeah.
yes, she needs to take a total of 100 microgram of estrogen plus 0.5 of levonorgestrel for 2 doses, 12 hours apart. So depending on what the dose of her estrogen is.
Gotcha. Okay.
You can also take progesterone only, a single dose, 1.5 milligram of levonorgestrel, or 2 doses of 0.75 of levonorgestrel and repeat in 12 hours. Mechanism of action of the copper IUD, with that it prevents implantation and sperm migration. It also decreases transportation of the ovum. For the Mirena IUD is the same, plus it causes endometrial suppression. It increases cervical mucus and decreases tubal motility. You talked about the types of hormonal IUDs and you said them correctly, so I'm not going to go over them. Benefits of using the Mirena IUD would be that it decreases blood flow. It helps treat endometrial hyperplasia. It helps with treatment of endometriosis, fibroids, and adenomyosis. Benefits of the copper ID, just like you said, it's good for emergency contraception and for longer contraception. Contraindications of the IUD would be a pregnancy, if the patient is pregnant, of course, if there is a significantly distorted uterine cavity, if there is unexplained vaginal bleeding, if she has gestational trophoblastic disease with elevated beta HCG, she has an ongoing pelvic infection, then you wouldn't want to put an IUD in her. If she has history of breast cancer, then you wouldn't want to put a Mirena IUD. If she has Wilson disease or copper allergy, you wouldn't want to put the copper IUD. Complications of the IUDs would be like expulsion, perforation, vasovagal syncope, infection, or pregnancy on top of the IUD. And if the patient does have pregnancy on top of an intrauterine pregnancy, you would talk to the patient that you can either, remove the IUD, which is probably the better option, and she might have a miscarriage, or if it remains, then there's a higher risk of chorioamnionitis, preterm labor, placenta previa, low birth weight, abruption, and increased risk of cesarean delivery. Okay, and somebody here, Carla, mentioned here that both Mirena IUD and Liletta are FDA approved for 8 years for contraception and 5 years for heavy menstrual bleeding. Thank you, Carla, for that information. Mirena and Liletta are approved for 8 years. Well, what did you say when you mentioned the duration?
I said 5, that it was FDA approved, but that it's effective up to 7. I didn't realize the FDA approval had been changed to 8. So thank you.
Yes. Okay. Thank you so much for attending tonight. And I hope this was helpful, and see you soon. Do you have any questions? Okay, Kirby's asking me, do you mind repeating the doses for estrogen and progesterone for birth control pills when being used for emergency contraception? Yes, 100 microgram estrogen, 0.5 milligram levonorgestrel for 2 doses, 12 hours apart. And again, it depends on what kind of birth control she's using, how much estrogen there's in it. And the progestin only 1.5 milligrams levonorgestrel. For a single dose or 2 doses of 0.75 and repeat in 12 hours. Okay. Thank you. Thank you, Emily. Okay. Okay, thanks everyone. I'm ending the webinar. Good night.